God and King, we thank you for this day. Thank you for what you have been doing among us. Thank you for the manifestation of grace and power. Thank you for your glory that is revealed. Thank you for our nation. Thank you, Lord, for the wave that is blowing. Thank you for this season. Lord, we thank you for what you have prepared for this meeting. We seek the spirit of wisdom and insight, the spirit of counsel from heaven, and manifestation of your power, even as we continue with this service. In Jesus' holy name we are worshipped.
I'd like to say good evening and welcome to everyone. You know, we say normally, thank God, another Shiloh has, yes. We thank God for this time. We thank God for all what we have been receiving, you know, all this while, the last 2 Saturdays. And now we've got the week here, the long-awaited week. And we're kicking off. My job is to introduce our main speakers and the teams around him, you know. And it's quite interesting that we're focusing a lot about health and wealth, you know. I mean, we know the popular saying that health is wealth. And this is the year of wealth, and this is the year of increased power. And you have to be healthy to exercise power. And so, the Light of the World have put in loads of programs, you know, addressing those areas. And this evening, before I introduce our main speaker, in Greenwich Borough, we have the public health team. And the public health team is coordinated, you know, by a young woman. You know, she looks younger than the last time I saw her. So I will have to say, oh. And she said, I'm Sheila Taylor. And I was like, oh, okay, you look younger than, you now look like your younger sister. And she is the main coordinator of the public health, you know, for the Royal Borough. Sheila Taylor, thanks for gracing this occasion. Also, in Greenwich Borough, we have what we call cancer awareness champions. Usually we have some doctors, you have some paramedics, you have other people in nursing and all the areas. And 2 Tuesdays ago, this doctor gave a lovely lecture about cancers in the Royal Borough of Greenwich and all the awareness. So, to come and sit in front, I'll call Dr. Caroline Hollington. She is one of the main cancer awareness champions for the Royal Borough of Greenwich. And she's doing some sterling work. Talking about someone who is doing some sterling work, our speaker. You know, I was just speaking with Sheila, and I was saying, okay, we need to find a urologist to give this talk. And Sheila was like, oh, I know who to call. You know, where you say, Bob the builder, we can fix it. It's like, I know who to call. The only person that can do justice. He's been doing a lot of work, doing a lot of promotion about this issue and other health issues that are prevalent, you know, among the black and minority ethnic groups and among the population, basically. He is a consultant urologist of note. You know, I was looking at his resume, and I just realized that actually we have a lot in common. he trained at University of West Indies in Trinidad, Mount Hope. And I happened to spend some of my, productive years also in Trinidad and Tobago. I worked at Mount Hope, lived at Mount Hope, worked at General Hospital, Port of Spain, trained some students there and everything. And it's like, looking at his resume, I was like, oh, okay, so we have a lot more in common than, And he then came over, did his surgical training in England here. I did the Royal College of Surgeons of Edinburgh. We say we are the best school. So he's a fellow of the Royal College of Surgeons of England, and he works at Guy's and St. Thomas's Hospital as a robotic urologist. You see, you don't get many of them, and when you have someone like that, and it does not just do robotic surgery for prostate cancer, it does aquablation. Aquablation is one of the latest, techniques in managing prostate cancer with, proven track records and everything. Please, help me welcome Mr. Jonathan Noel. Now, we've got one young lady there. I will let Jonathan do the introduction, but I'll just say you've got us tonight and you've got this evening. If you need to, you can just look up, but I'm sure you are okay to go. When you say yes, we will be there to assist you. And I've got some questions waiting here also for you, because we have what is called a Slido. Can we just flash the QR for Slido, where as your talk is going on, people, you can scan the QR code. If you have questions for him to answer, I've got some questions already, but if you have questions for him to answer, then please just put it down on the Slido and I will monitor that, and then we kick off. Okay, we're doing well.
Good evening, everyone. It's a real honor to be invited to speak here at such a holy venue. I was taken aback by the singing and the praises, and Sheila, we were really, I could feel your spirits moving. I mean, it was, today's my father's birthday, and we have lots of conversations about prostate, because it's my work, and he is 66 today. And my grandfather passed away from prostate cancer at age 60. So this is a little bit of a, forgive me if my voice trembles every now and then, but it's today was meant to be, wasn't it? Apostle Williams, thank you for inviting me. Elder Ajadini, thank you. And like you said, it was great to know that we are linked by Mount Hope. Dr. Alicia Mohammed is a medical student from Trinidad who's just come to visit for 2 weeks. And I said, I'm coming here tonight, not expecting someone visiting to be outside the hospital, but she comes because she's interested, and that has impressed me. So let's go ahead and talk about prostate cancer as well as non-cancer and the causes, diagnosis, and treatment. So my name is Jonathan Noel. I work at Guy's and St. Thomas's Hospital. I also work at Lewisham and Greenwich Hospital as well. So it's a joint position that I hold, and I think that's important because it maintains a continuity of care for patients that I may see at Queen Elizabeth or at Lewisham. Next slide, please. Just going back on my career journey, University of West Indies, Trinidad. It's clear if I look that way. Yes, I was in London until 2019, and instead of becoming a consultant then, I decided to dive into my passion, which is treating prostate cancer radically. And in the United Kingdom, 95% of surgeries done with a robot. It doesn't mean that we turn it on and I go and have coffee. Means that things are done with a lot more precision and vision, and we can be better than we were before the robot was introduced. And then I went to the US just to bump it up a bit more, and I became a consultant 2 years ago, last month. Next slide. That's my team, guys. Those are the consultants. That's Vit Patel, a real inspiration to me. He's done the most prostate surgery in the world. This is the team at Lister and Stevenage that trained me initially. And this picture is Queen Elizabeth Hospital in Barbados, where my mother resides. It's an island that's, those of you who aren't familiar with, where Rihanna's from, but it's also a very small island, 21 by 17 miles. But for such a small island, it has the highest rate of prostate cancer mortality, one of them in the world. Next slide. So prostate cancer or benign enlargement, what the causes are, PSA testing, diagnosis, treatment, a lot to pack in. If the slides are too busy, I may just go through the highlights, but I really want you to ask questions at the end, so I don't want to be a didactic lecture to you all for an hour. I'd rather have interaction as well. Next slide. The prostate is just an organ underneath a man's bladder. It's usually about a walnut size, and it contributes to the nourishment and production of ejaculatory fluid. The way it's assessed is either by imaging in 2024, but by examination as well, which usually means that men are very apprehensive to go to the doctor because the examination entails a simple 30-second or less finger examination to feel if it's rock hard, which would probably indicate that it's tumor, or if it's smooth, fine. Next slide. Why does it change? And people ask me all the time, why does the prostate change? Why does it have to change? Like any organ, organs can change. And they usually change either because we are getting older, our cells change, they don't replicate the same. But there's also external influences. There's also influences in us, our hormones, testosterone, we all have them as young men, give us vitality and energy. As we get older, the balance between your testosterone and your estrogen changes, and that can cause the gland to either get very large or change and become abnormal. We live in a culture today where processed food is easily available, cheaper than healthy food. And with all of the pressures of the cost of living, we are forced sometimes to have that just for nourishment. But it is not nourishing our bodies, unfortunately. It is a cause of cancer, of every organ. And we have to be mindful of that. Smoking. But the processed food probably leads to this one that I've highlighted. Diabetes, it's an epidemic. Obesity, it's an epidemic. High blood pressure. Cholesterol. The thing is, you won't know that you have these things unless you present to primary care. You can't live life thinking, I haven't needed to go to the doctor, I'm healthy. I would never advocate that. You have to get an MOT. You take your car or your vehicle to get an MOT, why don't you take your body? There's hereditary factors, so first-degree relatives, father, brother, sister, mother with breast can relate it to prostate as well. Other organ systems are related, but breast and family history with prostate is important. And how many of my patients come to me with a new diagnosis of prostate cancer and have conversations with their family, and then, oh, my father, my brother has just come up and told me he had prostate cancer. They never knew, they never had a conversation. We as men sometimes bottle up things a lot. We have to be more open and have conversations with our family members, because that's how we get awareness. My experience is women are very forthcoming and better at that than men. We have to step up. Next slide. The prostate changes, like I said, that's a normal one on your left side. You can see how your water pipe goes through the prostate gland. And then when it gets large, it can start to really obstruct and narrow your water pipe when it gets large. And that's where you present to the doctor, because you're having a slow flow. It's just plumbing. Slow flow, you're splattering, you're pushing, you're straining. So that may indicate that there's a large process. But just because it's large does not mean it's cancer. It can just be large and be benign. So don't let that create fear in you either. Let us make a determination. Next slide, please. When you come to see me at Woolwich or at Guy's, you'll pass urine in a special toilet. You wonder why? Well, that's because I'm looking at the rate of how much you're passing versus the change in the scale, and then it prints off a very fancy graph. So you have a bell-shaped curve, and I know you're passing urine fine. If it's flat like anything, you know that you're not passing with enough force. Maybe there's a blockage. I tell you all this because I just want you to be part of the journey and make the interpretation, understand. It's so enlightening when a patient comes to me. Oh, look at all these new things. Okay, sometimes it's a bit too much if they come with Dr. Google printed off and stuff, but I think it's better to be informed. Next slide, please. Next, click one more. Okay, click back. So benign enlargement of the prostate can come in various sizes, and I just thought we'd put some your everyday items so you can have an appreciation. Avocado on the extreme is, big, and sometimes it can be even bigger than that. But to treat it in this day and age for a benign enlargement is like buying milk from the grocery shop now. You have so many types. You have soya, almond, coconut, skim. There's just so many treatments out there. It's confusing for patients. It's confusing for some of my colleagues, I have to admit to you as well. It used to be that on a large prostate would take medication first. Of course you take medication. I don't put anyone to surgery right away for a big prostate. But if the medication fails, then we have to consider surgery to help you pass urine. And the surgery is either very minimal, where we just put what's called implants or staples to part it. That's called a urolift. That's one option. Or we can inject it with a fancy steam, and that changes the prostate shape over time. So these are little things that men are more interested in now because there's less side effects, mostly related to sexual function. So that's why they would ask for that. And that's on the extreme of your left. But those who just want symptom relief or are not prioritizing potency, erectile ejaculatory function, they need the inner core removed with surgery. Of course, you're asleep for this. Next slide. And click again, please. So that's where you're not resecting. Those are some of the items there. You may come across them, you may have heard of them. You can take these slides, don't worry. Next slide. And click again. That's when you resect, you remove the inner core of the prostate tissue with a laser or aquablation, which was mentioned in my introduction. The aquablation is a water therapy. It creates a channel, and then you can pass urine over the wall again, like a young boy. Next slide, please. So you can see the extremes. A normal-sized prostate, or one that's very big, very obstructive. The danger of leaving it, and why do we treat it? The danger is that over time you may not be able to pass urine. You may need a little tiny tube put into the bladder to help empty a catheter. No one wants to live with a catheter long term. There's some situations where that's necessary. If you were too unfit for surgery, for example, or very elderly, it probably would be weighed, the pros and cons, but most times we can get a catheter removed by doing surgery. But if your bladder can't empty, then that has impact on your kidneys. That's dangerous. Plumbing. Next slide. This diagram just demonstrates resin, which is an injection of water into the prostate, and it changes shape. And a lot of people ask me about that. if your gland is too big, you shouldn't get it. I or one of my colleagues would make that determination for you. But it's important that you come with your reading and you ask questions, and we'll give you advice on suitability, okay? Next slide, please. That's the resection I was talking about. So on the extreme right is normal tissue. We put a tiny telescope down the water pipe. You're asleep, obviously. And then we create a channel, and the channel is there on the left of the screen. Channels created. So this is for benign prostate enlargement. The outer casing is still intact. Okay? It's benign. And you're passing urine over the wall again. Because if you don't and you leave your bladder to fight against this blocked prostate, what happens is your kidneys suffer eventually. And that can cause long-term problems with blood pressure and other systems. Next slide, please. Just concentrate on the right, I suppose. The screen is on top is before, and the screen on bottom is after on the right side. That's the channel that's created. Majority of colleagues do a very good job, but there are risks of surgery. After you remove all that tissue, you can leak urine temporarily. Your ejaculation won't go forward, it will go in the bladder. So if you're still a man who may be planning to have children, or you just don't want that to be lost, that will be a problem for you. So you must stay that up front. Our colleagues would ask you, of course, but it's important that we know where you're coming from and what your expectations are as well, okay? The images on the right are just the corresponding scan. You see how big that prostate was above the numbers, and then how it looks after. It's a big channel. I hope this isn't, I'm not pitching this too high level for you and I'm losing everybody. It's just information. And of course, I'm taking my time in each slide so you can assimilate it. Next slide, please. PSA. You may have heard it, prostate-specific antigen. PSA, a blood test. PSA. Have you had your PSA checked? You're 60. No. Well, you know, it's contentious because in this country we don't recommend PSA screening, blanket PSA screening, but focus on high-risk groups, men with family history, and it's a simple blood test. But it can be normal or it could be abnormal, depending on the situation, depending on whether you had an infection, whether you returned from a long flight. This can drive up the blood test result. Then you need to get it repeated again. And it can be increased if you have an avocado for a prostate. It's just big. Here we get a big number. But it can also be increased for other situations. So it's on us to determine what that means. I usually repeat it again to see if it goes right down, and then I'm fine, okay? Or I would do, next slide please. That just shows that the PSA is in the bloodstream. Next slide. These are the references that can be found online. You may ask, oh, well, what's the number? What's the number that's for me? It depends on your age, the decade of life. Below 40, we tend not to screen, and I probably will get a question or a comment about that, I'm sure. They are very rare cases of men that younger than 40 presenting with prostate issues. As a general rule, we don't advocate that. Different countries will start screening from age 55, some from 50 with family history. Over 80, we tend not to screen for prostate cancer if the man is not going to have a projected life expectancy beyond 10 years, because we know prostate cancer grows slow. We want to put a man who's 87 years old in a chair to biopsy his prostate. That's not reasonable to me. unless he's running marathons and he's fitter than the average. But that is a determination and a conversation to have. Next slide, please. So when you get referred to me, this is what you get. And in the UK, we're really lucky to have this. I can tell you, and you probably know, you have relatives overseas, not everyone gets an MRI scan of the prostate. In the US, it's about 60%, because it's insurance-based. Costs a lot of money. Here, we've dropped it down to about 200, 300 pounds. It happens. Whenever you come to us, we get an MRI of the prostate. And it's changed everything now. So I always tell my colleagues in primary care, just an elevated PSA doesn't mean they're going to go straight down the line of over-investigation, over-treatment. An MRI is normal, bye-bye. Back to primary care, and if your PSA is at a certain level in the future, you come back to me. And that's good, that's reassuring. As I start to approach the screening age, very reassuring. MRI, prostate, normal, leave them alone. About 25% will avoid a biopsy. An MRI scan is actually good because it can sometimes avoid that initial need for a finger examination. Because if the finger examination is normal, I don't mind. I'm still going to do the MRI scan because there's some areas of the prostate that the finger examination will never be able to detect, such as this picture. If I can orient you, the finger examination takes place in the rectum, which is that circular structure in box C on the bottom, but the arrows is pointing to a potential tumor at the front of the prostate. I'd never be able to detect that. Hence why MRI is important. It can now see things that we didn't see before. So because of that, we're detecting a lot more significant and accurate cancers in a timely fashion and not leaving it to proverbial chance. Because we do MRI scan for all men in this country. We've shown that it is beneficial through really high quality studies. Now there are other parts in the world where it's just not affordable. For some reason or not, I don't know why, but we've got it down to about 200 pounds. Saving you from a biopsy is worth it, because a biopsy probably costs a lot more than that in terms of processing and slides and analysis. Next slide, please. I need to keep track of my time. Transrectal biopsy. Sorry, horrible picture. We don't do that anymore. I don't put probes in the back passage and needles to the prostate because that needle is traversing an area that is not clean and will cause an infection, and we don't do it anymore. Next slide. We've Trexited. Pardon the pun. Means the transrectal biopsy is gone. We've Trexited, okay? Thank you for laughing. Those are falling a bit flat. So transperineal means the needle goes through the skin, okay? The skin to the prostate. So in some centers, we don't even need to give you antibiotics. And I'm pushing for this in the Caribbean. Because if we can do that without antibiotics, the savings will be astronomical. All these antibiotics we're just throwing at people like Smarties. They cause the bugs to be resistant. They do. Because you have a flu and you go to your primary care, they don't want to give you antibiotics, not because they don't believe you, but they don't want a resistance in the community. We don't want resistance in the hospital. So we avoid antibiotics by using this technique. It's revolutionary, and it's something that we have led in Southeast London and is spreading throughout the country. However, there's some centers in the country that don't do this because they say there's no difference in terms of picking up cancer. What they don't say is that we're avoiding antibiotics. Now, why would they do that? I don't know. But that's for somebody to determine. Next slide, please. If we biopsy your prostate and we find prostate cancer, first of all, you should know that there's Macmillan support. You should have a clinical nurse specialist. They should be with you throughout the journey and be a point of contact for you. Obviously, I would like to speak to all my patients who have new diagnosis, but it's impractical. So this nurse specialist will be the point of contact for you and your doctor. If there's any questions, you should know that they are there. Gleason score of the prostate. You see 1, 2, 3, 4, 5. 1 looks good, normal. 2, yeah. 3, that's when it starts to get abnormal. So Gleason prostate cancer is 3 and above. So most people will say, okay, what's my number? This is where it gets a little confusing, because the number is usually 2 numbers. There's usually a 3 plus 3, or 3 plus 4, or 4 plus 3. You say, why are the doctors giving us 2 numbers? They can't make up their mind? No, that's not why. It's because the first number assigns the most populous finding on the microscope. If I'm seeing lots of 3, that's 3. If I see a little bigger speckle of 4, 3 plus 4. Correspondingly, I could say, if I see lots of 4, that's Gleason 4. A little bit of 3 plus 3. You could imagine the different risk profiles. A 4 plus 3 is worse than a 3 plus 4. Now you got it. I'm seeing lots of head shaking. Good. I've made everyone pathologists tonight. I'm really pleased that you're not in long, because that takes some time to explain and understand, and I know it's confusing. It was for me, certainly, as a medical student. Alicia's probably brighter than me, so she probably knows already. Next slide. So it's evolving, I think, the diagnosis of prostate cancer is evolving. I don't think we're good as we can get. Because what I've told you already is PSA has to be up, and then you get referred, and then I do an MRI. This study was just a snapshot. 2,000 men invited to be screened. 22% responded, poor response rate. I think it was around the time of COVID, so I would forgive that. Black men had 20% response rate correspondingly to white men, and that again has sparked lots of conversation. Why? And I hope me and colleagues alike will join in engaging more so we can answer questions about apprehensions to presenting to primary care. 2 of 3 men had Gleason 4. I told you that 4 number is bad. This is just random. And the PSA was low in the boots. I'm not saying that to scare you, okay? I'm not saying that to raise alarm bells. You just told me PSA up, doc. But because of that, Prostate Cancer UK are now considering MRI as the first point, not PSA blood test. Do the MRI as a screen. We'll have it in the community, you do an MRI as a screen, but that has to be done in a trial. It has to be shown to be proven to make sense. So instead of the blood test, you're going to get the scan straight away. And it makes sense. I mean, if you were to get a full body MRI scan, you would pick up things that you would never know were there. Well, you know, that is not practical en masse, but I think you can target specific at-risk groups to do MRI scans. Next slide. And next slide, please. Now we're going to go to treatment and side effects. I don't know whether I should just break for any questions, because I feel like I've been giving you lots of information so far. Or should I keep going? So you hit me with a tsunami at the end of questions. No problem. Okay. Next slide, please. Is the volume okay? Though the QR code to ask questions, we need to distribute that to people because they may not have it. So if you have prostate cancer diagnosed and it's not low risk, I should say low risk prostate cancer is 3 plus 3. 3 plus 3 is low risk. 3 plus 3 is low risk. 3 plus 3 does not need that. 3 plus 3 needs just to be watched. Because in the majority of the time, it's a puppy and ain't gonna do nothing to you. You just watch it. Do another PSA test, do an MRI scan in a year or 2 years. And we see each other in the surveillance clinic. And if there's a change, then we will discuss treatment. But 3 plus 3 does not need the reflex of getting surgery or radiation treatment. We're very good in the UK of doing that. We're really good in the UK of doing that. Other countries are very poor at doing that. I don't know why. But again, it may be financial incentives behind that. Or that they didn't do an MRI, so they don't really trust what they're doing. Radical prostatectomy in this country is 90% robotic. Why? Because you get to go home the next day. Versus 3-4 days, risk of blood transfusion, versus the open cut. Now we do robotic. Go home the next day. Some hospitals will send you home the same day if you were keen to do that. I prefer not to. That's just a personal preference. But less pain, overnight stay. Next slide. Can you go back to the previous slide? I wasn't going to go into this, but I'm going to go into it. So this robot, right, was made 20 years ago. And you know why it was made? It was made to be in one place. You see the surgeon there on your right, operating. And then the robotic arms were put into a military vehicle and would come and scoop out the injured soldiers, and then the surgeon is at base camp operating on them. A defense program in the United States came up with this. And they didn't think it lucrative enough. So it went to that. Whereas you are in the same room. So you get the benefit of using not your hands, but you get to use the vision, but you're not operating from another room or another distance or another country. Now, 20 years later, I just came out from a meeting today. They're considering doing what they call telesurgery, where an expert will be in one country and be able to operate on patients in underserved areas. So that's coming. You may have questions and concerns about that, like I do. Okay, I'm seeing the engagement. Because my colleagues stand up very proud saying, telesurgery is here. We can reach out our hands. It's good to know your views. Yeah, good, okay. So, next slide. Before we did the open cut, there's lots of blood loss. You needed a blood transfusion, lots of pain after. Now, those tiny little keyhole ports, they're just about under a centimeter. It means that you get to go home with 6 tiny little cuts on your tummy, and you get to move quickly, and you're home sooner. Next slide. So that's a little drawing pictorially of the prostate. You can see the little yellow spaghetti areas or the nerves. You try to peel those off safely so you can have your function back after. I must tell you, it is millimeters of difference between sparing a nerve or sparing cancer and leaving it behind. So it is a very tricky procedure. In fact, any of the cancer surgeons I know across the world will say that radical prostatectomy is a humbling operation. I often say my prayers before it because it is very unpredictable, okay? But that's why you have to really train hard to be good at it. Next slide. Radical radiotherapy is another treatment for prostate cancer. You may say, well, what makes a man more suitable for surgery versus radiotherapy? That might be a question. Usually for young patients, under 65, they mostly, we would say, steer towards surgery. Let's say under 60, Whereas Patients who are probably more than 75 years old, certainly I would steer towards radiotherapy. Why? Because radiation therapy is X-ray therapy. It causes changes in the tissue. But 10 years or more, there can be a secondary cancer that develops from it on your bladder or your rectum that's nearby. So if you're a young man at 50 with prostate cancer, radiotherapy is definitely not for you. You've got at least another 30 years of life ahead of you. We don't want you to be dealing with a secondary cancer, whereas typically 75, 80, we would accept radiotherapy because the risks are very low. That said, we still have men who are 75 who just don't want radiotherapy. Fair enough, it is a two-way conversation. But radiotherapy is good in terms of cancer control. It's the same as surgery, but different side effects. Radiotherapy means you have to come in and get sessions, typically about 30 sessions. You have to have hormone tablets a few months before, which can make you feel like you have menopause. Low mood, low libido, and some men will choose not to have that. And it can cause your bowel and bladder to feel a bit irritated. And you have your prostate still. So some men just prefer surgery to remove it and be done with it. So it depends on the situation. It's not one size fits all here, but definitely young patients, we steer towards surgery. Next slide. I'm slowly coming to the end now. This is called a spacer on the right of your screen. Why have I shown you this? Because radiotherapy can disturb your rectum, but we can put spacers, which are gel foam, that create a space between your rectum and prostate and protect the rectum. We would do that for patients who are very high risk of their rectum being disturbed for one reason or another. Next slide. And the disturbance in your bladder can sometimes be corrected by us. Before you have radiotherapy, we could do an operation to help you pee over the wall again. Because if you're not passing urine very strongly, and I give you radiotherapy, I'm adding more wood to fire. Do the operation, let you pass urine faster, then you can have the radiotherapy. But before I do that, I'd be doing that flow test, remember? That shape curve, to make an assessment. So the radiotherapy doctors now work very closely with me and I with them, so we can give you the best result. Next slide. So prostate cancer treatment is a triad. Cancer control. Right? Remove your prostate, your PSA should be undetectable. Potency, ability to have intercourse again, if that's your if that's your aim, then we would give you tablets, medication, try to get you there. It's not going to be the same as before, but we can try to get you there around 80% as it was before. I have to say, if a man comes with problems with erectile dysfunction before the operation, and we do the operation, you can't expect it to get better. Okay? Setting expectations is really important and something that I have to take time to explain. Leakage of urine, temporarily. In our series at Guy's Hospital, most of our men have no pads or have one pad for social reasons by 3 months. Sometimes it takes longer for various reasons. But there's also a psychological impact about prostate removal. And that's very humbling for me to say as a surgeon. I like to think that I can do the very good job and my patients are happy, but there is a psychological impact. I know that. I see that, and I am open enough to admit that. And it is only, next slide please. This was a slide taken from about sexual function after prostate was removed. And one of the men's views were, I've been married for 36 years. We've got to the point now where we avoid this situation. She said to me, I don't really want to, because you're disappointed. Because it's never what it used to be. This is taken from a study where we got men's views, patients' views, raw views, something that a graph can't show or explain. The other man said now he's going through a divorce, and our life was pretty good before. So, these are really humbling facts. Because the prostate is the nerve holder for the erections. So the earlier we can get prostate cancer treated, the better we can spare the nerves. Next slide. Which is why I implore people to present and not present late, when it's too late to do any nerve-sparing surgery. That's a lovely cake, by the way. Minimizing impact on sexual function. So you spare the nerves, or you do radiotherapy without hormones to make you feel like you have menopause. There's different ways we can do this, or we can give you medication before you have any treatment to really see how we can bulk up your erectile function. But, it's not only what we're doing for the prostate. It's not only a surgeon or radiotherapy doctor. It is you, it is your fitness. If you have diabetes, if you have high blood pressure, high cholesterol, overweight, of course your erections are not going to be good. So you cannot only say it's on the surgery. There are other things we can do as well and help you to get better control of your health, and that will boost your libido, your testosterone, your erectile function. Next slide, please. The difference in the two pictures you can see are obvious. It's a man on the right side, high testosterone, high mental focus, healthy heart, yada yada, you get my point. Okay? Whereas obesity can cause a decreased muscle mass, abdominal fat, constantly tired, low libido, low erection. Next slide. Leakage of urine. Some men wear a small pad just in case. Some men leak a lot more, and that may be because the cancer was so aggressive. To get it all out in one go, we had to go very wide. So again, early presentation and early determination of surgery is key. Next slide. And next slide. You ever heard of Kegel exercises, man? You can raise your hand if you heard about Kegel exercises, men in the room. One. Women, ever heard of Kegel exercises? Women? A lot more hands up. Because after childbirth, typically, or relatives have had childbirth, you know about the pelvic floor exercises you have to do to regain continence of your urine after childbirth. It's a normal process. The men have to do it too after the prostate is removed. The men should actually do it even before you engage with a urologist, because it helps with health to your pelvic floor, erectile function, good flow of urine. You should be doing the Kegel exercises with you at home. It's important, and it's a hard thing to teach, because sometimes men will clench their buttocks muscle thinking they're doing the right pelvic floor exercises. That's wrong. That's completely wrong. It's a small, subtle muscle. If you've ever passed urine in the toilet, men, and you stopped in the middle of it, maybe a phone was ringing off or something, you were stunned, you ever stopped your flow of urine in the middle of your stream? That's that muscle. Next time you go to the loo, you'll probably test it out. And that's the muscle that you have to isolate and contract and relax, contract and relax. And I tell my patients they should be doing about 100 a day after prostate removal. I'm like a gym instructor when it comes to that, because it's important for recovery. Next slide. This study is for those who may have done some reading on the Oxford Urology group. They put this study called the PROTECT study. Why do I bring it up? Because at 15 years they said men who had either watchful waiting, just watched them, surgery or radiotherapy, had no difference in mortality. And it then asked the question, why screen? Why bother? Why put me here to talk to you about it today? Well, I'll tell you why. Because the men who were just watched and have treatment had high risk of metastatic spread, needing chemotherapy, problems passing urine. Yes, okay, mortality or death was not a difference. Is that an excuse to not take action? Not in my book. And next slide. also in that study, when they had 3 groups of patients, 77% were low risk, 3 plus 3. What can I learn from that? 77% were low risk, 2% high risk. And it wasn't a diverse population of patients. 95% were white ethnicity. No London hospitals recruited. They say it's high risk patients of black ethnicity, so then why didn't you put that in the study? It's a good study, it gives us information, you just have to look at the fine print, okay? That's all I'm trying to say. And I think now we do MRIs, robotics. This study was not done at that time, but it is quoted a lot by some people to justify whether they need to do any prostate screening at all. It's called the PROTECT study. Good study, fine print is there on that slide. Next slide, please. So this is my summary slide, and then we'll close and we'll interact. See, the alarm is on, that's good. Benign prostate. Benign prostate enlargement does not mean cancer, okay? Just because it's big and it's enlarged doesn't mean cancer. We can treat you with medication, or we can do the telescope procedures. Early prostate cancer has no symptoms, so don't think I'm going through life with fine and I don't need to get anything checked. Has no symptoms in an early stage. It would be silly not to get checked while you take your car to the MOT. MRI avoids unnecessary invasive procedures. So an MRI is normal. I don't need to biopsy 25% of my patients that come through the door. And that's a good thing. So MRI is here to stay. It's not going anywhere. The only change in MRI is that it may become available in the community now. Like I said, just to be screened, no PSA blood tests. That's a future endeavor. And then the side effects of treatment, you should know what your hospital is offering in terms of support for side effects. Next slide. That's how you can reach me. You can reach me at Guy's. You can reach me here as well for patients who may be overseas. Next slide. And my websites are there too. I'm happy to talk to you at any time after this if you think of questions you forgot to ask me tonight. I hope it was informative. I hope it wasn't too over the top.
Thank you. I'll leave you with that mic. I'll take. Thank you for that informative talk. I could see you are trying to restrict yourself and everything. Okay, it's back up there. So, as I said, I've got a few questions. I mean, some of the questions you've answered, and so I was going through them, and some we just need to go through them. Okay, so we say, okay, prostate cancer is quite prevalent in the black and minority ethnic group. Some people would like to know why.
I get that question every time I do these talks, and there's been, I think it's different factors. I can talk to you about it in different ways, but I suppose the first thing is to say is that the tissue reaction to testosterone, slightly higher inflammatory reaction, has been seen in patients of black ethnicity. The tissues are more sensitive to testosterone, and that is advantageous in many ways, but also the prostate will change as you get older to be unfavorable. We've pinged down a few genetic profiles. HOXB is one of them that comes to mind. So if you're to get a genetic panel, you don't necessarily need one for everyone, but there are genetic predispositions for patients with black ethnicity that will have prostate cancer. We've shown out. How do we address that is a question. Do we then tell every man with that gene they must come forward and get their prostate removed before? No, that's not practical. The other thing is perhaps apprehension. We found in Southeast London that there was a missing, I want to say, a good few thousands of patients of prostate cancer being diagnosed in Southeast London after the pandemic. There was a big gap. Rectal, breast, lung, all of these cancer trends recovered after the pandemic. But prostate, there was like a missing gap. Through different public health or social awareness campaigns, we found that there was a little bit of apprehension to re-engage with primary care. I think the pandemic did a number on everybody. COVID, vaccine, your view on it or against it, and then you want to come and talk about PSAs. So we've got work to do, and which is why myself and colleagues are really pushing for community engagement. So you can quiz us and ask us and put pressure on us to give you the information you need to make you feel comfortable to present to primary care. Otherwise, what's the point of our role? What's the point of our jobs, if not to do this? But historically, they say it's worse in prostate cancer in men of black ethnicity. Those studies were done in the United States, which is a different healthcare system, and I think you can't really apply it across the globe. There's lots of socioeconomic disparities, historically insurance-based, economic-based. But like I said, in Barbados, I think Zimbabwe, and I definitely know Martinique, these are the Caribbean islands where they have the highest rate of prostate cancer. And I think there's a genetic predisposition.
Thank you for that. Now, there are a few questions that are related, and that's about the relationship between sex and prostate cancer.
Yeah, I had a line actually on one of those slides. Infrequent ejaculation can lead to prostate cancer. That hasn't been shown on a large-scale study, but it's been shown on small studies. Men who ejaculated more frequently had less risk of prostate cancer. So that has come up from time to time.
So, how many times in a week?
Well, there you go. They haven't come up with a recommendation from the Royal College of Edinburgh. I'm sorry.
Well done.
But yes, I think it's important because the process is good cardiovascularly and health-wise, pelvic floor muscle therapy, and also to decrease your risk of prostate issues. So, and mental health. Yeah.
Yes, and bonding.
And bonding and procreating. And yes, everything.
Okay. Thank you for that.
Okay.
Now, we talked about foods and all these latest foods and everything. So, is there any way to prevent prostate cancer? Food, lifestyles, or anything?
I think there's a way to prevent any cancer that may be coming because you have a genetic predisposition to it. It's probably already biologically written in your DNA. But there are ways to decrease your risk factors. So we did speak about eating healthy, obesity, diabetes, high blood pressure. You can do these things. Now, I'm not saying that I have some athletic-looking men coming through the door that have prostate cancer. Yes, that is a common thing as well. But more often than not, they may have had a family history. But to prevent it, I don't think anyone will have any recommendation to how to prevent it, but you can certainly decrease your risk profile. Sometimes the writing is on the wall for the man who has these risk factors that I mentioned, that they would get cancer. And don't forget, if you are healthy, no obesity, diabetes under control, or no diabetes, etc., there's heart benefits to be gained, there's lung benefits to be gained, bowel health is good, colorectal cancer as well can be caused by these things I've mentioned. So let's look at the wider picture outside of the prostate box as well.
Okay, thank you about that. I mean, you've answered most of the questions during your talk.
Fantastic.
Which is quite good. Let me just see any questions pop up since we've gone up. Does the lack of sex? No, we already talked about sex. Okay, you did mention it before, but it was a kind of silence. Someone wants to know, or some people wants to know, the purpose of the prostate gland. Can I remove my prostate, and what side effect or what problem will I get if I want to remove my prostate from a young age so that it doesn't get bigger?
Oh,
so what's
prophylactic.
The purpose?
A prophylactic.
Yeah.
I think that actress did something like that. Was it Angelina Jolie? Had a double mastectomy because she had a risk profile for breast cancer. I don't. Yes, the purpose of the prostate is to add to your seminal fluid, your semen, your nourish semen, so that you can have a very high chance of fertilizing the egg of your partner. So if you remove your prostate, then your ability to have children will probably go down absolutely. However, some patients who are young who have their prostate removed, we tell them to do sperm banking, so then they can have an artificial insemination of their partner to have children if they so wished, while they go through their cancer treatment in a timely fashion. So if it's removed completely, it will affect the body in the sense of your continence and your erections can sometimes be weaker. So I would not subscribe to prophylactic removal of your prostate. There are too many things that are going to impact you, and then the psychology behind it. And you removed it, and then it was a normal gland. You just did it to prevent something in the future that may never happen. That's a hard pill to swallow. I wouldn't subscribe to that.
Thank you. Let me combine these two together. It's all about screening. What's your advice about screening for someone who doesn't have symptoms? How often should they get screened? And at what age should men do checks? So it's just about screening for.
It's a great question. It's actually the question I was waiting for all night, because I think we're in a little bit of a pickle now in the UK where we don't advocate blanket screening. It's not recommended by the governing body called NICE. But it should be a two-way discussion with your primary care team if you had symptoms or a family history about the pros and cons of doing a PSA test. But that's a conversation. That doesn't necessarily mean you're going to go down the road of a PSA. PSA screening would mean that I would do a PSA on you age 50 or age 45 if you had lots of family history of it, and then do it every year. That's screening. That's regimented. I believe that you should do targeted screening. At-risk groups. I believe that patients with strong family history, father, brothers, first cousin, black ethnicity, should have a PSA check as a baseline from age 45. And if it's low, don't get it checked for a few years. We know that PSAs less than 1 at age 45 tend to come to nothing over the next 2 to 5 years. So that's a good kind of, okay, I know what my number is, move on. But PSA has its failings, as I've told you before, and that's where the MRI question is going to come into play. Should we just do MRI, community MRI, and then you know what it looks like? So I think the answer I'm giving you tonight is 2024's answer. 2034, maybe a different conversation. Maybe the MRI van is outside there, and as we all leave, we're getting our scan.
Yes.
Who knows?
Yeah, thanks for that. And just let me pitch it. Tomorrow is the medical day, and we won't tell Mr. Noel we're doing some screening for PSA, prostate cancer and lipids here tomorrow. So if you have a high family history, and if you are one of those with symptoms and things like that, just come along. We'll do some PSA and give you some discussion with your GP. As we said, doctors will be here to talk to you also, and then you can be appropriately checked. That's tomorrow from 11 a.m. to 5 p.m. And Sheila is coming with her team. And Charlton Athletics team are also coming. Thanks, Jonathan. Yeah, I think that's good enough. Thank you so much. It's a pleasure having you here.
May the Lord answer you when you are in distress. May the name of the God of Jacob protect you. May God send you help from his sanctuary and grant you support from Zion. May God remember all your sacrifices and accept your burnt offerings. May God give you all the desires of your heart and make all your plans succeed. We will shout for joy when we are victorious, and will lift up our banner in the name of our God. May the God of Abraham, the God of Isaac, the God of Jacob, may he open a book of remembrance concerning you. May the God of Bethel, who appeared unto Abraham and Jacob at Bethel, may he reveal himself to you, even now and forevermore. In Jesus' holy name.